Hi, my name's Yvette, and today we're going to be talking about polycystic ovarian syndrome. In this tutorial, we'll discuss the clinical presentation, the investigations and how we diagnose it, and we'll look at the management and some complications. We're going to be using up-to-date guidance from both NICE and ARCOG. So, PCOS is one of the most common endocrine disorders in women of reproductive age. It's characterized by two things, by anovulation and hyperandrogenism, which is the excess of hormones like testosterone. It usually presents in the teen years or early 20s, affecting approximately 1 in 12 women, although the numbers can be as high as 1 in 4, depending on the criteria we use to diagnose it. There are higher prevalences in certain ethnicities, for example in South Asian, and there's both genetic and environmental components. And although the full etiology isn't known, insulin resistance is implicated. So insulin resistance leads to more insulin production, and that leads to hyperinsulinemia. Hyperinsulinemia will result in two things. Firstly, the ovaries will produce more androgens, like testosterone, and secondly, the liver will produce less sex hormone binding globulin, which usually binds to testosterone in the blood. These changes can result in increased free androgens. So we're going to look at a case now. So Sarah Smith is a 24-year-old lady who presents to the GP with fertility problems. She and her partner have been trying to conceive for the last 13 months. In terms of her gynecological history, Sarah started her periods age 11, and she describes them as always being irregular and infrequent. So we define oligomenorrhea when periods occur infrequently. This means that they occur more than 35 days apart from each other. So, for example, the woman could say that she has 6 to 9 periods a year. In Sarah's case, her last period was 41 days ago, and she has no other past medical history or family history of note, and she's not on any current medication. In terms of on examination, Sarah is quite overweight with a BMI of 28. She has active acne lesions on her neck, and she also has facial hair and the sign called acanthosis nigricans, which is this dark skin coloration or a velvety thickening usually found in the neck and the armpit, and this can be a sign of insulin resistance. We usually use the Rotterdam criteria to diagnose PCOS, and you need 2 out of the 3 criteria below. So amenorrhea or oligomenorrhea for more than 2 years, or evidence of androgen excess, which could be clinical, for example, excess hair, or biochemical, so the blood hormone levels. And the third point would be polycystic ovaries on ultrasound, which is defined as 12 or more follicles in at least one ovary, or having an increased ovarian volume. And it's often described as this string of pearls. In terms of the blood levels, there tends to be a high luteinizing hormone and a high LH to FSH ratio. The androgen levels are also high, so for example, high testosterone, and she'll have a low sex hormone binding globulin. As always, clinically, you would have to exclude other causes, for example, hypothyroid or hyperprolactinemia. In terms of managing PCOS, the first line is giving lifestyle advice and encouraging weight loss. This is primarily because PCOS is associated with many different conditions, including obesity and subfertility. So subfertility actually affects up to 75% of women with this condition. They also have an increased risk of different metabolic disorders, including diabetes and cardiovascular disease. They'll have an increased risk of sleep apnea and an increased risk of endometrial hyperplasia and cancer, and that's because of the infrequent periods. So often they need screening for additional conditions. If they do want to become pregnant, then the first line would be a medication called clomiphene. This is known as a selective estrogen receptor modulator, which binds to the estrogen receptors and blocks them in the hypothalamus and pituitary to increase LH and FSH release. It's given to women with a normal BMI, and it's meant to induce ovulation, so it deals with the subfertility side of PCOS. It can be used for up to 6 months, and it can be used with or without metformin. Usually, metformin is added after 3 failed cycles, and clomiphene slightly increases the risk of multiple pregnancy. Second line for women wishing to conceive would be laparoscopic ovarian drilling. This is a procedure which destroys ovarian stroma so that less testosterone is produced, and that is promoting ovulation. If the woman doesn't want to conceive, then you can consider the combined oral contraceptive pill or cyclical oral progesterone. This can regulate menstruation. It can also protect against endometrial hyperplasia, and it's also been shown to manage the excess hair and acne. You can also consider topical anti-androgen agents. So to summarize what we've said, PCOS is a major cause of female subfertility, and it's characterized by oligomenorrhea and hyperandrogenism. The first line for fertility management is usually clomiphene. So that's the end of the tutorial. I really hope you guys found it useful.